Good morning, everyone, and thank you for being here. I want to thank Director of the AIIMS, Dr. Srinivas, for hosting API at one of the premier institute of India, AIIMS. I want to thank and welcome all the API delegates who came all the way from US and some other countries for this exciting 2 days here in New Delhi and subsequently 2 days in Manipal, Karnataka, which will be our other part of the GHS, API GHS. At this point, I would like to invite the panel of the first CME speaker, Dr. Bharat Barai. Can you please come up here? Dr. Manmeet Ahluwalia, please come. Dr. Vijay Kumar, company for this event, EMED, Ms. Priya, for doing this CME in less than 48 hours. So thank you for all the hard work and welcome everyone. We're going to have a very exciting session of all very, very acclaimed CME speakers for this morning and later this afternoon. So welcome everyone.
So he's a regional API director, as you all know, right in the morning. And he is president of the Monmouth Ocean Medical Society. He is also appointed member and of the NG Senate, New Jersey Senate, and is board of trustee, Medical Society of New Jersey. And sir has numerous accolades to his name, and he is author of many textbook chapters, multiple manuscripts. And we welcome him to Delhi and India. And his talk will be on advances in management of brain tumors. Over to you, sir.
Thank you. Thank you. Okay, so we're going to talk today about recent advances in management of brain tumor. Before I start, I always start my talk with this because as a neurologist, I'm also a neurologist in addition to neuro-oncologist. So if you have any talk more than 20 minutes, and that's the reason I kept my talk and every other speaker's talk for about 20 minutes, is this. When you give a talk more than 20 minutes, you will start doing this or that or this and eventually this. So human brain can only concentrate up to 20 minutes. So we give talk longer than 20 minutes, this happens. So what happened is when I was working in New York, Sloan Kettering, I was hoping to start New Jersey's first brain tumor center. So my goal was cutting edge care, peace of mind here at home. So here in your backyard, I can provide the advanced level academic care. And that's when we started our brain tumor center in New Jersey. So I always say that when people hear the brain tumor, they always worried about deadly situations. So I said it is still very hopeful situation. So what is hope? Hope is one more good day. Peace, the possible, the first step to success in treating the brain tumor. So we know that the brain tumor is unlike any other disease. We take very aggressive team approach to find the answers and provide the hope. We play to win. We want survivals. Just giving you a little brief about what neuro-oncology does. So many of places, the neuro-oncology is kind of very unknown field of medicine because it's a very small field of medicine. Not many people are aware what neuro-oncology does. So that's neuro-oncology is a medical discipline that addresses the diagnosis and treatment of primary brain tumor, metastasis and non-metastasis complication of systemic cancers, symptoms associated with cancer that affect the CNS, pain, fatigue, depression, palliative symptoms, and management. So why it is very important? Neuro-oncology is extremely critically important in coming decades because nervous system symptoms are common in a patient with any cancers, and I'll show you why. Look at this slide here. Almost every cancer patient during their lifetime, there will be some neurological symptoms and there will be need for neuro-oncologists. You can see all different cancers in this slide. The problems are increasing. What happened is when people with breast cancer and lung cancer, with the recent advances in treatment, they are living a lot longer. And now they are developing neurological complications. So you're going to need neuro-oncological care. The problems are serious. As you know, brain is very tight sanctuary. Not all chemotherapy can penetrate the brain. Diagnosis is often difficult. The more importantly, I want all of you know today here, and few things that I want you to leave this room today with, there is a hope and there is a treatment in when it comes to the malignant brain tumor. Treatment helps at some time at a cost. Problems in neuro-oncology are unique. Of course, research is very essential. So the unique aspect of neuro-oncology, that brain and a spinal cord are, as we know, enclosed in a bone. So small lesion can cause very large symptoms. The blood-brain barrier excludes many chemotherapeutic agents, and CNS does not possess the capacity of clinically significant regeneration. So when damage occurs, you cannot regenerate the part of the brain. So an occult cancer can destroy nervous system, what we call paraneoplastic syndrome, where absolutely nothing really structurally wrong in your brain, but patient is completely disabled neurologically. So just give you very brief about epidemiology, diagnosis, and prognosis. And I'm talking about CBTRS. This is a statistics in United States. 14 to 16 cases of 100,000 people. This incident of brain tumor, man to female, is about the same. About 40,000 new cases of both primary, benign, and malignant brain tumor occurs in US, and glioma occurs about half of them, and 80% of them are high-grade tumors. 1.32 of all the cancers are brain tumors. Why this is very critically important? Because, as I said earlier, it's a very aggressive and a deadly tumor. Half of the patient will die. 15,000 deaths occur due to primary malignant tumor, and lifetime risk of having a brain tumor is about 0.6% to 0.5% from male to female. So just to give you a little brief about distribution of primary brain tumor by the site. So as we can see here on this cartoon, primary brain tumor, brain, cranial nerve, spinal cord, excluding the ventricle cerebellum, is about 63%. Meningeal disease, what we call meningiomas, is about 22%, and the other small group in different locations in the brain. So distribution of all primary brain tumor by histopathological type, and that we mentioned. So meningioma is about 27%, glioblastoma is 23%, astrocytoma is 11%. All others are, we can see, small percentage, but the largest group is meningioma, which is a kind of benign brain tumor depending on size and a location and a pathology, and then glioblastoma, astrocytomas. So this is also very, very important to understand and know that in brain tumor world, we do not stage brain tumor. We grade brain tumor. So if it is a low grade or higher grade. So what we call low grade astrocytoma, low-grade oligodendroglioma, low-grade ependymoma. Depending on the origin of the cell of the tumor, we call the brain tumor type. So low-grade anaplastic and glioblastoma, or low-grade or anaplastic oligodendrogliomas or ependymomas. So as I said earlier, we grade the brain tumor. So grade 1 and 2, we call it low-grade brain tumor. So normally speaking, we used to, actually not anymore, we used to say low-grade brain tumor, we either do the surgery or just monitor even without any surgical interventions. Grade 3, which is anaplastic astrocytoma, which is about 1/3 of the 30 to 35% of the gliomas, we have to treat them aggressively because they have potential to become grade 4, which is glioblastoma multiforme. So epidemiology, diagnosis, prognosis, median survival, and importance of histopathological grading. So pathological diagnosis is extremely critical in determining treatment and prognosis. So in recent years, we, and I'm sure everywhere here in the world as well, treat cancers at personal molecular level. We do molecular profile. We're going to hear a bit more about this later, but we treat every cancer based on the genetic profile of that individual cancer pathology. So low-grade oligodendroglioma, median survival is 4 to 10 years. I have a patient with 25 years with low-grade oligodendrogliomas. Low-grade astrocytomas, survival is 5 years. Anaplastic oligodendrogliomas, 3 to 4 years. And astrocytoma, anaplastic, less than 3 to 4 years. And glioblastoma is about 12 to 14 months. So type of tumor is extremely critically important. And that's why I always tell people when I see the patient first that your prognosis depends on what kind of tumor you have. Not just having a brain tumor is equal for everybody. So how we diagnose brain tumor? And some of the slides I will go a little fast because I only have short time to finish. So MRI is a gold standard of diagnosing brain tumor, MR spectroscopy, PET scan, perfusion diffusion MRI, cerebral blood volume testing, now chromosomal analysis, genetic testing, nanotechnology. So once you diagnose people with brain tumor with all the recent advances in imaging studies, how would you treat? So gold standard of treatment for the brain tumor, I always tell people that I want to have brain tumor in a jar, not in your brain. I prefer the brain tumor in a jar, outside the brain, not in a brain. So the gold standard is to remove the brain by a very good skilled neurosurgery team. So overall objective of the surgery in a treatment of CNS malignancy is bulk reduction. And this is extremely, one point that I want everybody to live in this room with is the prognosis depends on how aggressive initial surgery is. If the neurosurgeon can go in and remove 90 to 95% of the tumor, that person will respond well no matter what kind of tumor person has, including the glioblastoma. If we can only remove 20, 30, 40% is as good as doing the biopsy. Also the surgery we need sometimes for the palliative of the symptoms. Biopsy we need for the tissue diagnosis, and sometimes we use brachytherapy, implantation of the chemotherapy device. So surgical technique for the resection in malignant gliomas are also different. We do open surgery, stereotactic biopsies, awake craniotomy, intraoperative MRI imaging guided surgery. So there are lots of new advances in neurosurgical technology at present time. So once we do the surgery, what is the next step? So next step in treatment, of course, when I see the patient first, we discuss about whether there's any better clinical trial available after the surgery. Of course, the gold standard for initial treatment for malignant brain tumor, what malignant glioma is radiation plus chemotherapy, what you use now as a temozolomide, which is an oral chemotherapy, radiation plus another chemotherapy agent, and a radiation therapy alone. These are the treatment options. So radiation therapy, objective of the radiation, we're going to hear more about from our radiation oncologist, but overall objective of the radiation in treatment of CNS malignancies include potential for a cure in some cancers, prolongation of survival, and control of local infiltration of the cancer cells, and sometimes just the palliation. There are also multiple kinds of radiation. We're going to hear more later about that, so I'm going to skip this. So this is my role starts as a neuro-oncologist. After the surgery finishes, I always tell my patient in my office that I am your quarterback. I will be your main physician. Once your surgeon finishes their job, I will now take care of you as your brain tumor care doctor. So what do? I do a lot of different kinds of chemotherapy depending on individual patient's tumor type and molecular profile. So the chemotherapy options we have here, we can see on a slide: temozolomide, bevacizumab, BCNU, CCNU, carboplastin, irinotecan, procarbazine, vincristine, and the combination of different drugs. So this another thing that a lot of time people as a knee-jerk do when you have a patient with the brain tumor, almost every time people will give them a anti-epilepsy medication, seizure medication. So if person had a brain tumor, not necessarily that person will have a seizures, and not necessarily that person need epilepsy medication. Unless that person had a seizures, we do not give them a seizure medication. So I take them very quickly off anti-epilepsy medication, because a lot of anti-epilepsy medications are hepatic cytochrome P450 inducers. So when we give the chemotherapy, that will destroy the chemotherapy a lot faster. So if we don't need the seizure medication, we stop that. Steroid, if we need, we can give them steroid without any worries. Bypassing the blood-brain barrier is very important. So the first drug that United States FDA approved for brain tumor was the temozolomide, and this was the radiotherapy plus combination temozolomide that made the US FDA approve the drug. And this has changed my life from now and then many people across the world what happened after that initial combination therapy. Because we used to do radiation and a temozolomide before we did this publication. So this, what we did is, I'm going to show you this very quickly, tell you the story in less than 30 seconds. So this is the patient that comes to me in 2004 with malignant brain tumor, and he was told that he will not survive more than 2 months. He was seen by all the major neuro-oncologists in a country, comes to my office with 11 family members, and I said, I can disagree with everything told to you, but I have something in my mind, I'm going to try. And with no other better options, he agreed for the chemotherapy option that I gave him. This was his initial MRI, and there's so many other scans, but I only put one picture. He had a multiple recurrent glioblastoma, and this was his pre-treatment baseline MRI. And we gave him 2 cycles of bevacizumab and irinotecan, which is a combination chemotherapy. And when I saw his MRI first, after just 1 month of his 2 cycles of chemotherapy, and I was surprised that 100%, almost 100% of his enhancing tumor disappeared from his brain. Nothing like this ever happened in glioblastoma literature, published or heard, or even as a case report like that. So that led to many more clinical trials, and then later on, United States FDA approved one of the chemotherapy combinations that we published that in initial 2004-2005 Society for Neuro-Oncology and Clinical Oncology initial trial. So what is the challenges that we feel with the personalized treatment for primary brain tumor, tumor-specific treatment, histology, grading, molecular profile? So why one treatment works for one patient and not for other people? So some drug predicted good response to the drug or a combination of drug. So some people predicted poor response or no response to the particular drug, and some people will have progression of the disease. Same treatment, same disease, everybody respond differently. So what are the prognostic factors for a brain tumor? So I always also tell people that if you are a young, neurologically intact, and surgeon removed most of the tumor, you will respond well to the treatment. What are the molecular prognostic factor in glioblastoma? So there's a lot of single agent, single genetic agent that we have discovered now, what we call MGMT, EGFR, PTEN, IDH, all different genetic markers that we look into the tumor cell, and multi-gene profile. So now what we're doing is a multi-gene genetic profile that look at different things into the cell type. So why molecular prognostic factor are important? So we initially discovered MGMT promoter methylation status, where MGMT promoter methylation, if you have the glioblastoma patient will respond and survive longer to one particular type of brain tumor with the one particular kind of chemotherapy, we use temozolomide. I'm going to skip a couple of slides. So true predictive factor for MGMT methylation status, that was made the temozolomide FDA approved in our country, United States. I think I don't have too much time because I only have 3 minutes, so I'm going to skip some of the slides. So this is the target for vascular growth factor receptor inhibitor, what we call bevacizumab. So this was the reason the United States had approved one of the drug that I used in a first. Before FDA approved, we have the second highest patient in the world in a literature published from my practice before United States FDA approved bevacizumab for the recurrent glioblastoma in a clinical trial, what we call brain study that was done, and at the Duke study in the United States. I have 3 minutes to go. So choosing the target is extremely important, because what happens if you choose the wrong target, this thing happens. I mean, many of you guys don't know. I'm sure my colleagues from our US team here would know this joke well. So target is very, very critically important. optimizing the anti-angiogenetic therapy for recurrent glioblastoma is extremely critical because all different type of treatment will only respond if have genetic profile in a different ways. Bevacizumab combination for recurrent GBM with different chemotherapy agents are also being used and are being studied at present time. We are also doing additional chemotherapy and newer anti-angiogenetic agents at present time. Of course, I don't have enough time to go in detail of each one of them. Now we're doing a glioma stem cell research. So we're taking out the stem cell and engineer them in a lab and then injecting back to those stem cell with different patients, what we call brain tumor vaccine trial. IDH1 and IDH2 mutation, which is another newest advances in management of brain tumor. And I'm going to also go very fast here. And this is what I want all of you to know here, that Society for Neuro-Oncology has established in India now. There was no neuro-oncology society in India. So Society for Neuro-Oncology in United States outreach with Indian physicians, oncologists, neurosurgeons, and radiation oncologists, and established Society for Neuro-Oncology of India in Indian subcontinents. And there is a tremendous need of Indian neuro-oncology as the patient numbers and care are needed so much in great demand here. So neuro-oncology practice in India is tremendous. The patient numbers, expertise and communications are in great need. So at this point, I have 1 minute. I'm going to stop here, and this is my team, my family here, and my practice, my brain tumor center team, my CEO of the hospital, and my CFO. These are my neurosurgeons, radiation oncologists. This is the person who gave me the money to start my brain tumor center, which is David Azachi Brain Tumor Center, with my administrator. So I'll stop here, and with the interest of time, at 0 minute, I will suggest that we will not ask any questions, and I also ask all the speakers to keep their talk under 20 minutes so that we will stay on time. Thank you very much for your attention. So at this time, I'll invite our second speaker, Professor Vijay Kumar Srinivasan. His introduction was sent to me by our Dr. Chabra, and I probably, it's like as long as my talk, but what I'm going to summarize his introduction. He's retired from University of Mississippi Medical Center and retired from University of California, UCLA Davis, retired University of Illinois, Chicago. He is currently personal sabbatical for several months following 41 years non-stop academic and clinical career to explore the new senior leadership, entertaining the opportunities regarding think tank consulting, deanship, cancer center directorship, senior advisor position, strategic planning, and scientific communications. He is also President, Cancer Care Advisor, and Consultant, LLC. So welcome, Dr. Vijay Kumar Srinivasan.
Good morning, everyone. I see a lot of young faces there. How many of you are medical students? Please raise your hands. That's great. Fantastic. I love it. So you can put it down. And you are the future. So this talk is meant for you, okay? And what I'm going to talk about today is radiobiotherapy and radiobiomedicine, okay? The first lecture Dr. Sibal gave was like an introduction to my presentation, because he showed all the data that show how far advanced India is in terms of digitalization. Without that digitalization, artificial intelligence is not going to be easy. So since there is so much digitalization, including I have seen, I go and shop for a fruit, I buy for 200 rupees, and I have my smartphone show that whatever the scan is, boom, it gets out of my account. So that other countries are learning from India. So why not other countries learn about cancer care from India? Because India has many advantages right now. And that's what you young guys to hear from this presentation of mine and go and do some PubMed research, start getting new ideas, be creative, and start writing papers, get grants, and go ahead. Are we there? Anybody who wants, give me a clap. Good. It's not for me, it's for you. All right. These are the medical students who have worked on this project with me. And some of them have written 3, 4, 5 papers with me. And those are the young minds that need to be mentored, okay? So these slides, I'm being told that will be sent to you, and you can understand many ways to forge ahead by going over the slides at your leisure later on. So, what is the hypothesis? The hypothesis is radiotherapy is like surgery. It's a local modality. What do I mean by that? It controls the cancer where it is given. However, radiotherapy had been there for close to more than 100 years. But when you combine with other modalities, chemotherapy, etc., 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 it works much better, okay? So the new kid on the block now is the immunotherapy. When you combine that with radiation, we call radioimmunotherapy. But we have chemotherapy, we have targeted agent. What are targeted agents? For example, in brain, the MGM and other molecular alteration diagnosed by something called NGS, next generation sequencing. And based on those mutations, you can use certain drugs that can target those specific mutations and get improved outcomes. And when you combine that with radiotherapy, that is called radiobiotherapy, okay? I worked with one of my residents, and his name is Dr. Sanjay Joseph. He was an internist, board-certified medical oncologist, hematologist, and he wanted to work with me. We wrote this editorial together. Unfortunately, Sanjay passed away because of the COVID. And this presentation is dedicated to him. Fantastic guy. Anyway, we coined 2 new words, radiobiotherapy and radiobiomedicine, because the future is combining radiotherapy with other drugs to accomplish better outcomes. The whole purpose of the future radiobiotherapy is to improve the local control, improve the survival, and most importantly, decrease the complications and improve the quality of life. So the hypothesis 2, this is 2024, what I am proposing is the original hypothesis of precision population medicine, which is use of precision medicine at the level of population, combining with AI, can really take cancer care to the next level. You know how the telephone companies, we have the 1G, 2G, 3G, 4G, 5G? This radiobiotherapy can take the cancer care to maybe 10G. At least that's a hope. Because it's a hypothesis. You young guys have to go and prove that is true. So I want you all to go, take the next flight to go to Manipal, because I am following up with a talk that will address the precision population medicine and improving cancer care, and how India can leapfrog, take advantage of all the things Dr. Saibal told in the beginning to become the cancer care guru for the world, Vishwa Guru for the world. So the next 10 minutes, I'm going to review the literature quickly in the past 6 years. So this is cutting edge information for you, and hopefully that will lead to knowledge. So what will radiation oncology will look in 2050? This question was addressed by these German researchers. And the arrows show that we need to focus on basics research, scientific education, prevention, early detection, improved treatment, of course. But this is where our focus is going to be. At the old age of 62, I went back to school and studied for Master of Public Health and graduated at the old age of 66. Why did I do that? Because applying the knowledge of public health to cancer care can make a huge difference in the future, because a stitch in time is better than, you know what the answer is, right? So using AI and other computer prowess, we can make the future much better, and I'll show some data. So for example, in this review, something called stereotactic body radiotherapy. Essentially, stereotactic body radiotherapy means giving extremely high doses to a very minuscule volume, and you destroy it. It's actually called radioablation. But the example I want to give is the old radiotherapy is using like a sniper. Okay? The new radiotherapy of stereotactic is like throwing a grenade. But the old radiotherapy was indiscriminate, but the new radiotherapy is very pointed to the target. When you give a very high dose, what you do is you release so many antigens, the body did not even know that that was foreign. When you do that, the body's immunity starts producing new antibodies and other cellular immunity producing enzymes and cells, and that is called radioimmunotherapy. So when you combine that kind of new antigens in the body, your results are so much better. And there are data to support that. I'm not making it up. So this European Oligocare Consortium found out in this 108 papers, culled out of all these literature search, like a meta-analysis. I'm just summarizing. The data currently are scarce or absent. That's why you young people have to go out and get it. Some site-specific combinations may have toxicities that need to be carefully studied. And how do we study? Clinical trials. That's where we are heading. So the advantage India has is due to the paucity of data, large international registry trials are recommended. I'm sure the medical students may not know, or some of you may know what registry trials are. Registry trials are taking individual treatment information in a digitalized form and combining it so that at a future date we can do something called data mining. And the data mining is possible only when you have very robust database and ability to analyze the data with statistical software. With the AI, you can really do fantastic data mining, and that's what is possible because in India you have so many patients with cancer, more than other countries. With that kind of robust database, you can do extremely outstanding data mining that can help not only patients in India, but patients everywhere in the world. This study is a patterns of care survey study in German-speaking countries, and that again showed that there are so many drugs that were studied in terms of combining with radiotherapy. But look here, the highest number of participating centers were clinics. That means most of the treatment in India are given in the small private practice circumstances. So if the digitalization that is possible today in India can be leveraged to get a huge registry of all the information, just imagine with the use of AI, how much data mining and how much research and how many papers and how many grants you can all get. Unbelievable opportunity. This gives the details of radiotherapy for you to go home and read. And there are many conclusions, but these are all the conclusions here. So let's not get lost looking at the trees. Let's look at the big picture of the forest. What is that? That is, here, these arrows show something called abscopal effect in radioimmunotherapy and radiobiotherapy. What is abscopal effect? You know that, let's say that a surgeon operates on a tumor and the patient has a metastatic lesion elsewhere, you don't expect operating here will help the other tumor, will you? Okay. Now, if you give radiotherapy to a tumor, and if this tumor over here disappears, that's called abscopal effect. And it does happen. You know why? Anybody tell? Immunity. I told you that throwing the grenade. That's what happened. The new antigens lead to get new antibodies, and that leads to abscopal effect. See how many times the abscopal effect is happening. So this is advantage India because there are multi-center observational studies are recommended, and India has a registry. Before that, see how many papers are getting published on all these new areas of developments. So this area is growing so fast, unbelievable. If I get a chance, if I'm as young as you guys are, I will do medicine with data sciences together so that you can be a great cancer care scientist. So the take-home message, multimodality and multidisciplinary care is the name of the game in the future. And India is poised to take off because of the computational and digital prowess, artificial intelligence, and so these are the advantages for India. So I talked about radio immunotherapy, which is a component of radiobiotherapy. Just focus on these blue squares and rectangles. This is an example of oncometabolites that will be released when you do radiobiotherapy. I'm not going to go into the details because each cancer behaves differently. This is another set of oncometabolites. Now, if you look at the global radiotherapy, India access to radiotherapy is pretty good for India. It just sits in the middle in terms of the League of Nations. Similarly, if you look at the number of centers, India is doing very good except this small middle part of India. And if you look at the distribution of coordinated research projects from IAEA, International Atomic Energy Agency, look, India does better than anybody else in the world. So there are lots of advantages for India. So the take-home points for radiobiotherapy status, multimodalities therapies are going to be the norm for radiobiotherapy. Precision medicine in cancer care based on targeting and immunotherapy are here to stay. Multiple actors are involved. For example, for each cancer, you need 4, 5, 6, 7, 8 specialists. To put everything together, you need digitalization, artificial intelligence. There is no other country better than India to take off in the future. So I have only 2 minutes. I think you'll come and cut my neck, right? If I exceed the time. So all I want to say, there is something called clinical trials registry of India that already exists. So all we have to do is to make sure this CTRI is even further enhanced in the future. And this particular database, compared to 2013 to 2023, is amazing. There is so many new things are happening. For example, in the next slide, I will show that. See how many more trials India is doing in this past 10 years compared to the other negative going down because of the COVID. So I'm going to go to the final summary. This was meant for an hour-long talk, but then I was told it's only 20 minutes. So don't get mad at me for getting you petit mal. You know what happens petit mal when you keep changing? If you clicks, you get petit mal, right? I hope nobody gets it. All right, here is the final slide. Before he brings the knife, I will send all these slides for you guys, and I will ask you to do some homework, okay? I'm a tough teacher. So, digital revolution, telemedicine-based clinical trial management, easier digital database management, easier data mining, ability to become clinical trial center for the whole world in terms of new ideas, new clinical trial designs for rural areas, new telemedicine-based clinical trial executions. These are all possible. Sky is the limit. Young people, think big, go for the sky. And here they will say, go for the sun with the ISRO. Thank you.
Thank you, sir. And because of the interest of time, we will move to the next speaker. It is indeed my honor and privilege to introduce our next speaker, my mentor my teacher and my senior colleague from oncology, Dr. Bharat Barai. Dr. Barai had kept many different types and served at many different organizations and many different capacities. So he's a medical oncologist as the medical director of oncology hematology. He is a clinical assistant professor of medicine, Indiana University Medical School, chairman of pharmacy and therapeutics, co-chairman, again served as a board of directors. He had done many clinical trials in oncology in the United States. He also served as the state of Indiana as a president, vice president, secretary, and a member. He is a very well-known clinician, clinical hematologist, oncologist, and a well-respected human being as a physician and API leader. I'm humbled to introduce my mentor, Dr. Bharat Barai.
Thank you, Sumul. I'm going to take you through a journey. What have we achieved in treatment of breast cancer in last 140 years? Today in the United States, 90% plus women who are diagnosed with breast cancer are expected to live 5 years and beyond disease-free. So when Dr. William Halsted introduced his modified radical mastectomy and published it from Johns Hopkins in 1894, what has happened in last 135 years that we have gone from 40% long-term survivor, and that was also in early stage breast cancer where they did mastectomy, to more than 90% women living disease-free 5 years and beyond. So it's a journey and science. So let's start. So breast cancer affects 1 out of 8 women in USA. There are about 297,000 cases of invasive breast cancer and about 55,000 DCIS. In India, about 1.38 million new cases are diagnosed with about 450,000 deaths per year. So there are various things that play the part. One is the role of hormone replacement therapy. Till about 15 years ago, many women in menopause used to get supplemental hormones, and we found that added about 8% to the cases of breast cancer in USA, and now it's not being done, and I hope it's not being done here too. The role of diet, it's a small role, but animal fat. Now many people say, yeah, I'm a vegetarian. Well, truly we are not, because we are ovo-lacto-vegetarians. Many people eat eggs, many people take milk and milk fat, and the cholesterol which is contained either in butter or mao or whatever you eat, paneer especially, that is an animal fat. Genetic factor, about 5 to 10% of breast cancers are genetics related, and family history and genetic is probably intermingling. Environment, very little. So let's start the primary prevention to try to get better survival. If you get no cancer, you survive. So avoidance of hormone replacement therapy, reducing dietary fat, the role of vitamin D. I'm sure many of you know that vitamin D has been associated, low vitamin D, with increased incidence of breast cancer as well as colon cancer. So having an optimal level of vitamin D is certainly helpful. And the role of mammography. Now we know that the survival in breast cancer is dependent on the stage. The earlier stage you diagnose, longer is the survival. So if we can prevent the cancer or try to detect it very early, and that's where the role of mammography has come. In many countries, I don't know about India, but in USA, all insurance companies have to pay without any copay or deductible for mammograms. And when I was a fellow at Northwestern University, almost 20% patients were coming with early stage 1, less than 1 centimeter tumor. Today, with widespread adoption of mammography, almost 50% women are diagnosed with tumor less than 1 centimeter size, and of course, will get better survival. And now it has become from zero mammography to 3D mammography, which has become a standard of care. It started in 2011, and now we are able to pick up even smaller tumors. And when there is question, high-risk patients, we use MRI. The initial treatment for breast cancer was, of course, surgery, and depending upon the stage, different kinds of surgeries were done. 100 years ago, it was almost surgery. Dr. Halstead published his paper from Johns Hopkins in 1894, which, believe it or not, was almost standard till 1970, when they started comparing modified radical mastectomy, which was not as much butchery, certainly not removing the chest wall muscle. Then came the modified radical mastectomy by Dr. Madden, and lumpectomy in 1977 became a standard when National Surgical Breast Adjuvant Program published that whether you do lumpectomy plus local radiation therapy or you do modified radical mastectomy, results were same. And then in 1994 came the sentinel node biopsy. Did we really have to remove all the lymph nodes from the axilla? And many women suffered from lymphedema. And the results showed that if you do the sentinel lymph node biopsy, it was as good as full axillary node dissection. Now, my colleague talked about radiation therapy, and they use either external beam radiation, IMRT, high-dose mammocyte balloon. But now we have come to understand that breast cancer is not one disease. It's a biologic and therapeutically different, and that is what has improved our results. So let's start with hereditary screening. We know that about 5 to 10% of breast cancers are hereditary related. And it was in 1996 that BRCA1, BRCA mutation testing started, and now in the panel, PALB2 is also added. So in last 25 years, this has allowed us to do the testing. About 37% of patients should be tested. Now, I should tell you that with the testing that we have today, it's our belief that only about 30 to 35% of hereditary cancers are picked up. So science has still to come up with more genetic mutations which may be associated with hereditary cancer. And so what are the red flags? When the breast cancer occurs below the age of 50, ovarian cancer at any stage, male breast cancer at any stage, multiple primary cancers, Ashkenazi Jews, and the relatives of BRCA mutation carrier. So what does the science tell us? Those who have look at the breast cancer by the age of 50, those who have BRCA mutation, almost half of them will develop breast cancer before the age of 50. And by the age of 70, almost 87% of them will develop breast cancer. So whether you are Angelina Jolie or Mr. XYZ, if you have this genetic mutation, you better take care of yourself, and it's a treatable situation. If you do the mastectomy bilateral, you can reduce the incidence of breast cancer by 90% in those who have BRCA1, BRCA2, or PALB2 mutation. Can you use tamoxifen? Yes, it acts to a degree. Some people also do oophorectomy if they had BRCA mutation to reduce the risk of second breast cancer. And those who have BRCA mutation and family history of ovarian cancer, as soon as their reproductive life is over, should go ahead and have THBSO. Now we go to the era of systemic therapy. So we went through surgery, we went through radiation therapy, we came to about 50% 5-year survival. And the first trial was done realizing that cancer is a systemic disease. By the time the cancer reaches the size of 1 centimeter, which most people will consider small, it has a billion cancer cells. And it represents the 30th generation cancer cell. So when you are seeing a 1 centimeter size cancer, the cancer cells there are the 30th great grandchild of the original cancer cells. And during the growth, from the first generation to the 38th generation, some of the cancer cells, they escape into the lymphatics, they escape into the blood sensor. And that's why the word cancel. People used to believe that when you got cancer, you are canceled, which is no longer true, at least not in majority of people. So it is that understanding that in majority of patient, cancer is a systemic disease. It's not a local disease. Yes, early cancer is a local disease, and local treatments, whether radiation therapy or surgery, does play a very important part. But if we are going to cure cancer, we have to kill every cancer cells, not just take out 90% of the lump or 95% of the lump. So the first trial on that hypothesis that patients should have surgery to remove bulk of the disease and get chemotherapy or some sort of systemic therapy, that trial was done in Italy by Dr. Bonadonna, and it was published in 1977, where pre- and postmenopausal women, after so-called curative surgery, where all the known disease was taken out, were given chemotherapy, and at that time it was cytoxan, methotrexate, and 5-FU. And as you can see here, we see the difference in people who are treated versus control. There was a difference, 61 to 54%, and those that were node positive, there was also a difference, and overall survival was also different between the two groups. So it was the first time it was established that by giving systemic therapy after surgical treatment, we will make a difference in survival. And the hypothesis was that those cancer cells that were hiding somewhere were killed by our systemic treatment. Now today, even with all the best imaging modalities, we cannot detect a cancer till it is about 4 millimeter size. Whether you do CAT scan or MRI or a PET scan, 4 millimeter is the earliest you can detect. But a 4 millimeter tumor will contain 300 to 400 million cancer cells. So when you think that you have detected cancer early, biologically, that's not true. You still have 400 million cancers sitting there. So we have to go and kill those cancer cells if we are going to achieve cure. And then came hormone therapy. We know that breast is an organ that is dependent on hormone for its growth and for its regression. So, truly speaking, the word should be anti-hormone therapy rather than hormone therapy. And tamoxifen came as an anti-estrogen somewhere around 1975-77. Then came other drugs like raloxifene, and then came aromatase inhibitors. Even in postmenopausal women and even in men, the adrenal gland produces dehydroepiandrosterone and androstenedione. And the enzyme aromatase converts these compounds into estradiol. So even in a postmenopausal woman, there is a small amount of estrogen that is produced by conversion of dehydroepiandrosterone and androstenedione into estradiol. So the new generation of drug came, anastrozole, letrozole, and exemestane. So this was the results with hormone therapy tamoxifen in those women who had estrogen receptor, progesterone receptor positive. And this is with aromatase inhibitor that was used. So we kept on biting 2% here, 5% here to keep on adding to our cure. So we reached about 70%. So who are the 30% that we were still losing? Then another thing that came is called breast cancer index, or BCI. This is highly prognostic, especially in premenopausal women who are hormone receptor positive, and it gives a percentage of likelihood of cancer coming back between 5 and 10 years. That also helps us, BCI, not only say prognosis, but who are the people, who are the women who should get 5 years of hormone therapy versus 10 years. So BCI is used. Those people who have low BCI, we try to give them hormone therapy for 5 years. Those who have high BCI, we try to give them hormone therapy for 10 years. So this you try to incorporate. But when people are getting hormone therapy, those of you who are treating would have noticed that some of these people, even with hormone receptor, estrogen receptor 70%, progesterone 70%, become resistant to hormone therapy. What happened? Why do they become resistant? So then we found that almost 40% of these people who become resistant to hormone therapy develop ESR mutation. So anybody who develops resistance to hormone therapy should be tested for ESR mutation. And now we have drugs that are available which are called selective estrogen receptor degraders. And one drug has been approved by US FDA. There are 4 of them developed, but elacestrant. So if a woman becomes resistant to hormone therapy, you test for ESR mutation, and if ESR mutation is present, you treat them with elacestrant. Now, elacestrant was approved just about a year and a half ago. Then we came another class of drugs because we knew that hormone therapy alone was not sufficient. So CD4K inhibitors, and there are 3 of them. So today it is standard, not only we give hormone therapy, but we also give them CD4K inhibitor that further improves their survival and long-term survival. Now, another thing, when we are doing hormone receptor assay, estrogen receptor, progesterone receptor, HER2 new receptors, we are only testing for 3 genes. But are only 3 genes taking part in the biology of breast cancer? The answer is no. And after study, they found that a 21-gene assay called Oncotype DX is a lot more accurate in predicting the prognosis for breast cancer than a 3-gene assay, which is cheaper. So if you can see here, the recurrence score, if someone has a high recurrence score based on the 21-gene assay, they have 30% survival or 30% chance of developing recurrence. So now women who have tumor which is more than 5 millimeter, have no involvement of axillary lymph nodes, they are ER positive, how do you find out who is going to be high recurrence score? So the funny part is, you think that a tumor which is small will always be good. Look at here. 16% of women with less than 1 centimeter tumor had high recurrence score. So these are the women who should get chemotherapy. And on the other hand, more than 4 centimeter, almost 46% of them had low recurrence score. So they don't need chemotherapy. So now we are able to further differentiate who should get chemotherapy even with axillary lymph node positive, estrogen receptor positive. And below the age of 40, yes, we know that below the age of 40, it's more aggressive, but in 41%, not everybody. Almost 44% of them have low recurrence score. So those women below the age of 40 do not need chemotherapy. So who are the 30% that we are losing? HER2 new. When there is overexpression of HER2 new, those are the people who did much worse. So by targeting, and the first drug that came out in 1998 was Herceptin, then came lapatinib about 10 years later, then came the era of antibody drug conjugate, where you combine, it's like a laser-guided bomb, that it goes to the particular target, which is HER2 new, but it's combined with a poison. And there is an internal dimer that pushes the poison selectively into the cancer cells. For example, the first drug was TDM1, which was combined with maytansine. Then this is a structure, I'll go quickly, but you can see the difference as compared to chemotherapy. TDM produced alone much better results. Then came pertuzumab in 2008, which is another HER2 new blocker, and the two combination produced better result than using pertuzumab alone. Now, in 2022, very interesting understanding came. We used to classify people who were HER2 new 0, 1 plus and 2 plus as HER2 new negative. If they were positive, HER2 new 3 plus or by FISH. But a new category has come called low HER2 new. So now we no longer call them HER2 new negative. If you say HER2 new negative, that is HER2 new 0. But HER2 plus 1 and plus 2 are classified as low. And look at what has happened. We have a drug called trastuzumab deruxtecan. So even in people, it worked in people who have HER2/3 positive, but look at, even in HER2 neo, this drug is effective. So now we say, hey, is it 1+, 2+? We do have a drug that we can treat this patient with HER2 neo. So controlling HER2 neo has added about 15 to 20% to our cure rate. So now we have gone from 70% to about 85%. So which are the 15% which are our worst enemies? Triple negative breast cancer. I'm sorry, so now PARP inhibitors are one drug, but the breakthrough that has occurred is the immunotherapy. So today, I just want to show one side. Women who have 2 centimeter size breast tumor, triple negative, 15 years ago, most of them used to die. Today, when a combination is given of chemotherapy and pembrolizumab or atezolizumab, 64% of them go into complete pathological remission. And we know that if they go into complete pathological remission, this is what happens, the top line. And at the European Society of Oncology 2 months ago, they presented even better data. They said their complete remissions rate were almost 80%. So now, 2/3 to 70% of people who have triple negative breast cancer, most of whom used to die about 10 years ago, we can rescue them. And that is what has pushed our cure rate or long-term survival rate in breast cancer to about 90% plus. Another drug, very quickly, is antibody drug conjugate. This is bringing out a lot of new drugs in oncology with a lot more effectiveness. So a drug called sacituzumab that came out for triple negative breast cancer, both metastatic as well as neoadjuvant, and it has given remarkable results. And that is directed against TROP2 antigen. So now we have another target besides HER2 neo and HER2/3, TROP2 antigen, and this drug is specifically ADC against TROP2 antigen. And there is one more drug coming. It is not FDA approved yet, but we expect DXd to be approved sometimes in 2024. And now we are finding the new mutation, and there are two new, besides ESR1 mutation. One is the PIK3 mutation, and there is a drug, alpelisib. So we test them, do they have any other mutation? And another mutation for which a drug became available in November 2023, just about 6 weeks ago, and that drug is called capivasertib, and whether it's a PIK3 mutation, AKT1 mutation, or PTEN mutation. So now you can see how the journey has gone in last 130 years, where our understanding of biology and trying to personalize the treatment has made it possible today when a woman comes in my office to say, ma'am, you have more than 90% chance of living your God-given life. Thank you.
Thank you, Dr. Barai, for those historic information. Our next speaker, before our break, and with the interest of time, since we are little running late, we will shorten our break, so we will come back within 10 minutes once this talk finishes. So our next speaker, good friend of mine, Dr. Manmeet Ahluwalia. Manmeet is Chief Scientific Officer, Chief of Medical Oncology, and a Deputy Director of the Miami Cancer Institute at present time. Prior to his current role, Dr. Ahluwalia served as an enrolled professor and a physician scientist at Cleveland Clinic, where he built the world-class brain tumor clinical trial program. He led several landmark clinical trials in neuro-oncology, resulting in over 250 publications. Currently, he is a recipient of NIH R01 grant-funded investigator on AI-based radiomics in glioblastoma, total $3.9 million grant. He served as a clinical trial leader on NIH PO1 grant of over $10 million based on gender-specific differences in glioblastoma. Welcome, Dr. Manmeet Ahluwalia.
Thank you so much, Sumal, for a very kind introduction, and thank you to Inderpal, Chabra, and the organizing committee. I know we have a very varied crowd, and I'm the last speaker in between you and the break. So I'll try to give you a flavor of some of these aspects of immunotherapy and precision oncology as we are treating our patients. This is my disclosure slide. So in US, really, the fight against cancer started in 1971 when President Nixon signed this act to really invest a lot of resources into cancer. And as a person in healthcare, resources are extremely important. And Anupam Sibal gave a great, very eloquent talk in the beginning how India can be a world leader. But this was what put US as a world leader against the fight against cancer. And what has this resulted in? This has really resulted in a 32% decrease in mortality if you look at the figures compared in the last 3 decades. So we have done well, but there's a long way to go. And President Biden has a very ambitious cancer moonshot program to decrease the cancer mortality by 50% in the next 25 years. And how are we going to get there? So I'm not going to speak on cancer screening, which I think is going to be a big part of it. But this was really the Time magazine cover almost 23 years back. And this was the new ammunition against war against cancer. And these were magic bullets. And these were what we referred to as targeted therapies. And some of the previous speakers very eloquently have covered what these are. And these are drugs that actually target these genetic alterations which drive cancer. And a classic example of that is CML, or a chronic myelogenous leukemia. It's a type of leukemia which used to affect people in their ages of around 40s. And the average survival before these targeted therapies was around 2.5 years. And the only treatment was an allogeneic transplant with a considerable mortality at that time point. Now with Gleevec and a number of other drugs which have followed that, the average lifespan of these people is a normal life. And 10 years survival is around 85%. So we have really transformed the outcomes of these patients. This is a tissue agnostic approach. Obviously, you heard a very eloquent talk on breast cancer. As we've really evolved, what we are figuring out is cancer is not an organ-based disease. Previously, we were taught or trained to treat patients with, say, brain tumors. Dr. Raval gave a terrific talk on treating brain tumor patients. Dr. Bharat had talked about breast cancer. Now what we are finding out is there are genetic drivers of cancer. And depending on what the genetic drivers are, we can actually pick a drug. And the same drug can work for a lung cancer patient compared to a breast cancer patient or someone even with colon cancer. So I'll just give you one example. This is a pretty busy slide of NTRK gene fusions. These occur in around 1% patients with cancer. And some of the common cancers have 1% alteration like lung cancer, breast cancer, or melanoma. Uncommon cancers like salivary gland cancers have expression rates which are very high. Typically, when people had this kind of alterations with their regular chemotherapies that we used in the clinic, the outcomes were only around 12 months for a stage 4 disease. And now with this kind of drug, the responses are 80%. That means the cancer either shrinks or goes away completely. And the average outcomes is 5 years or more. So we have now really increased the outcomes of these patients by 5-fold. This is a very busy slide. Again, this is basically some of the precision medicines that have been approved in oncology. It just tells you that the future is bright. We have a lot of opportunity to make a difference in life of the patients that we serve. And every year, there are dozens of drugs being approved by the FDA. And a number of these drugs are actually even coming to India. Sometimes the pricing is a challenge in India, but definitely it's something to follow very closely. Obviously, Dr. Bharat mentioned about the antibody drug conjugates. And basically what these are previously when we gave chemotherapy, it was like basically bombing, right? So you would go and bomb and you'll have civilian casualties or you'll have people you really want to eliminate. As we've moved into antibody drug conjugates, really we are having now smart bombs. And this is what like a Trojan horse. So you're using these receptors which reside on the cancer cell, which is not going to be there on a normal cell. And essentially, using that, the linker then is targeted to a payload, and the payload then goes and releases the toxin. And essentially, what this has done has really revolutionized the treatment of a number of diseases, and he very eloquently covered about the breast cancer, where you can see that TDXD doing well against TDM1. So TDM1 was the first generation antibody drug conjugate. TSD is the latest kid on the block. But the takeaway point for people who will ever think of going into cancer is that typically when we had one drug approved compared to a second drug, typically the difference was only around 3 months or so, because that's how challenging cancer is. So when we put a patient on a chemotherapy, we hope that we'll be able to give them a 6-month benefit before the cancer will unfortunately grow. This is for stage 4 disease. But if you look at their TDM1, the benefit was 7 months. And when you got TDXD, the benefit was 29 months. So not only did we improve it, we really hit it out of the park. And the hazard ratio is 0.33. So the lower the hazard ratio, the better it is. So typically we would get drugs approved for a hazard ratio of 0.7 or less. And here you can see the hazard ratio was 0.33, which I think has been transformative for these patients. What was even more exciting, which Dr. Bharat already covered, was the benefit of TDXD, this antibody drug conjugate that targets the HER2 pathway, was the HER2 low patient population, where we were not expecting it to do well, but it did much better than the standard chemotherapies and has really revolutionized this outcome for these patients. Next 7 minutes or so, I'm going to talk about immunotherapy and give you a flavor. There's a lot of excitement about immunotherapy, and there was a mention of immunotherapy combining with radiation, abscopal effect. And basically what we have is our body is really capable of getting rid of these dysfunctional cells, which actually get generated every day we live, whether it's a byproduct of aging, it's a byproduct of environmental challenges like pollution. We have in Delhi, there's a lot of research now coming out that environmental pollution is a risk factor for lung cancer. And women with EGFR lung cancers who are actually non-smokers are getting it because of environmental exposure, because the particulates less than 0.25 microns can be a risk factor for that. So similarly, our immune system actually gets rid of these dysfunctional cells almost every day. But what happens is that these tumor cells are extremely smart. They induce a shield around them, and there's a mark or a receptor on them called PDL1. Here you can see it in the red tumor cell. And the T cell, which is supposed to kill the tumor cell, has a receptor called PD1. And what the tumor cell does is it actually engages with this receptor and turns off the T cell. And now what we have is we have antibodies which can actually target the PD1 pathway or PDL1 pathway. And when we combine these antibodies, actually they go and attach on these receptors and actually then disengage the T cell from the tumor cell. And then the T cell becomes actually activated and it can actually kill the tumor cell. And as a result of this strategy, you can see again, this is a very busy slide. There have been a number of immune checkpoint inhibitors, which refers to these antibodies against the PD1 pathway. And the most common one, if you want to remember one name, is pembrolizumab. And this is a drug which has a significant number of approvals now. It's being used to treat patients with lung cancer, head and neck cancer, and numerous other cancers. Have really revolutionized melanoma treatment as well. And just to give you an example of what these anti-PD1 drugs are doing, traditionally when we used chemotherapies, here with the blue curve, you would have a stage 4 lung cancer patient where an average survival was around 12 months. And now with these immunotherapy, the average survival has actually more than doubled. And a 5-year survival has gone up from 5% to more like 20 to 25%. So as you can see, these drugs are truly revolutionizing what we are doing to help our patients in the clinic. Just to give you another example, this was deemed as the miracle drug, dostarlimab, and this was an NEJM paper, but also had a lot of coverage in the New York Times. And this was the first time in the history of mankind when they treated 14 patients with colorectal cancer who have a mismatch repair gene alteration. And what that does is colorectal cancers, typically, you unfortunately have to resect them. You lose sphincter control. There's a lot of problem with the anal cancer specifically. Then you have to give them radiation and chemotherapy, which leads to a lot of problems. Of the 14 patients that they treated, all 14 of them had complete responses. That means the cancer went away completely. So it was only the first time in the history of mankind that we had a complete response in in the initial number of patients. So got a lot of press. Obviously, we don't expect the results to pan out that favorably for the entire patient population. But what we are figuring out is in this era of precision oncology, when we are doing genomic profiling for our patients, we can really pick what are the drugs that will benefit them, whether they are precision oncology drugs or whether they are immunotherapy drugs. There's a lot of interest in CAR T cells. And basically what we do here is that we take patients' blood to generate T cells. Then we actually make CAR T cells in the labs. Then we genetically basically altered them against the CAR T protein that we want to use. And it's the protein of interest which is seen in the cancer. And then we can grow them in the lab and create millions of these cells. And then we can transfuse them back in the patients. And these CAR T cells essentially then go and kill the cancer cells. So these are really charged T cells now, which are very heavily but precisely directed against the target. And this is a great example of Emily. Basically was a young teenager who actually was not even a teenager when she had leukemia, and she had received number of lines of chemotherapy, and the physicians actually told her that she had no other option but told her parents to take her to hospice. That means there's no treatment for such kid. She was actually treated at the Children's Hospital in Philadelphia when they were testing CAR T cells from Carl June's work. And essentially they gave her this CAR T cell therapy, and now more than 10 years later, she's actually cancer-free. So from going from death bed, she really has now gotten her driver's license. So this is how we are really transforming patients and their lives, at least some of them that we can touch. CAR T cell therapy has mostly shown benefit in heme malignancies and not shown benefit in solid tumors so far. Just a little bit of a snapshot of our own work. Dr. Raval gave a very eloquent presentation on brain tumors, and the one which is the most difficult to treat in brain tumors is called glioblastoma, which is the most common type of brain tumor we see in United States. Same tumor Senator Kennedy had, Senator McCain had, and son of Joe Biden, Beau Biden had. And typically these patients only live around 15 to 16 months. So this is a vaccine that I've been associated with, and for full disclosure, I have equity interest in this company called Mimivax that actually has developed this vaccine called Cervax-M against the survivin protein. So survivin protein is only expressed on cancer cells, and we've seen that in 95% plus patients with glioblastoma. And essentially what this vaccine does is when you give it, patients will actually mount a mid-affinity. Again, the T cells get revved up. But what we are also seeing that there is an antibody response, and we are looking at whether we need to generate a CAR T as a result. So in the initial trial that we led when I was at Cleveland Clinic in collaboration with Dana-Farber, Mass General, and Roswell Park, we've shown actually a benefit of 1 year. And right now, the vaccine is undergoing FDA registration studies. So what is the future? The future is really bright. As was mentioned initially in the first few talks, we are in this era of artificial intelligence. We are in this era of precision medicine, precision oncology. We need to recognize what are the genetic drivers of a patient's tumors, and then we can either pick the precise radiation therapies as was specified earlier. We can pick the targeted drug, antibody drug conjugates, or immunotherapy. So we are just scratching the tip of the iceberg, and you can see the iceberg here. And I think going forward, we'll make tremendous progress in our efforts against cancer. So in summary, we've seen exciting changes in oncology, especially in the last 2 decades. Revolutions in genomics is here and is only growing. Molecular-driven trials, independent of histology, are reshaping cancer care. Immunotherapy, as you can see, has truly resulted in transformative changes in outcomes in a number of tumors. I gave you example of lung cancer, but there are numerous examples like that. AI will further enhance our efforts in cancer care. So for the medical students in the audience, I think you are going to graduate in the most exciting era of healthcare. So all the power to you as you'll take care of us as we all age. Thank you so much for your kind attention.
Thank you, Manmeet. And this will conclude our morning session. We will take 10-minute break. 10-minute break. Please come back within 10 minutes because we're running late. And we will see you soon. Okay.
Before we take break, sorry to interrupt,
Yeah.
we'll need to honor our speakers and moderator. You've been very modest to go without that. So may I request our president of API, Dr. Anjana Samadar, please come over and honor our speakers and moderator. Dr. Samuel N. Rawal, please. Madam, come forward, please. We call everybody doctor here, sir, not MD. You can all come forward, please. Then Professor, round of applause, please. थोड़ा नींद भी खुल जाएगा. I am sure you must have not slept. Professor Vijay Kumar Srinivasan, it was a wonderful session. Dr. Shivangi also, please. Dr. Bharat Barai. Dr. Bharat, please. Please hand over the moment to him. Photographer, are you taking the photos? Madam, please honor Dr. Manmeet Ahluwalia. Dr. Manmeet Ahluwalia. So now the noon says, thank you everybody. Have a good group photograph, please. So मैं भी आ जाऊँ?